This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director of Education at the AARC. I welcome you to today's presentation, Applying Simulation to Stay on the Leading Edge. Upon completion of this AARC webcast, participants will be able to describe the key sequential elements of the curriculum instructional design model and process, discuss the role of simulation, particularly in the RT hospital-based education, review simulation strategies used for RT education, competency, and assessment, and explore the role of the hospital-based clinical educator in the future. I am pleased to welcome Ms. Roberta Hales. Robbie is a respiratory therapist, neonatal pediatric specialist, registered nurse, and the senior simulation educator in the Center for Simulation, Advanced Education and Innovation at the Children's Hospital of Philadelphia in Philadelphia, Pennsylvania. She is also a faculty member in the Medical and Healthcare Simulation Program at Drexel University School of Medicine in Philadelphia. Robbie is also a member of the AARC Simulation Roundtable. Robbie has no relationships to disclose, and I disclose that I am a paid employee of the American Association for Respiratory Care. Robbie, welcome to the program.
Well, thank you, Shauna, for the introduction, and thank you to you, Ellen, and the AARC for inviting me to share my thoughts about simulation-based education and respiratory care in a hospital clinical environment. I hope I can give each one of you one thing you will take forward and use in designing respiratory education in the future. I really just said, as Shauna already said, I have no disclosures, but I just wanted to make sure I was upfront and told you that I had no conflict of interest. But what I really would like to do is expand a little bit on what Shauna said about me and tell you a little bit about myself. I am the Senior Simulation Educator at the Center for Simulation here at the Children's Hospital of Philadelphia. The program began approximately 10 years ago, which is when I left the clinical field to become the lead educator. I am also currently in my second year as an associate professor at the Drexel University College of Medicine in the Master of Science in Healthcare and Medical Simulation program. I do hold a Master of Science degree in Healthcare Administration, but I also have a concentration on my degree which goes towards adult training and organizational development. I have been in the healthcare field for more than 30 years. I spent the majority of it as a critical care pediatric respiratory therapist, and I've also am a registered nurse with a few years of experience. I am currently in a new position with the International Pediatric Simulation Society. I am one of their education co-chairs, but have recently been elected to be on their board of directors. So I'm going to say it's a little bit enough about me, but I do want to tell you that I am a Philadelphia Flyers fan, and I'm so far looking forward to the season beginning in another month. So we already went over the learning objectives, and I just, I changed the order of them just a little bit so they made sense as we go through the sequence. But we're really going to try to look at that process of education and how can you use simulation, which is an educational strategy, to move forward in your educational session in your institution. You know, respiratory care knowledge of advanced medical technologies, together with you guys knowing about patient physiology and anatomy, is essential for us in order to provide that high quality care. But you know that things are becoming more complex. Things are changing, and it's really difficult to keep up with the new technologies and the new processes and the new evidence-based medicine as we move forward. So today what I'm going to familiarize you with, and some of you might already be familiarized with this, is the process of curriculum development and instructional design. This will help you to define what you're teaching to your group of respiratory therapists. And then we will end with exploring what does it look like for the future for the respiratory therapist as a hospital-based educator. Now, I know you guys already answered this, but I'm going to ask you to answer it again. So what is your role? And again, I'm going to direct you up to the little polling thing up in the corner. What is your role as staff therapist, clinical therapist? Are you an educator, or some people call them professional developers, a director, supervisor, or none of the above, which means you would probably do something else. For me, I would pick none of the above because I'm none of the other three ones. So I'll give you a few seconds so we can see what the poll says. And this really will help me as I'm speaking to you on how to direct this presentation. So really, if you think about it, when you talk about curriculum design and instructional design, one of the first steps that you're going to learn that you do is something called a needs assessment. So I'm doing a little mini needs assessment right now of who you are. So who are my targeted learners on this presentation? Okay, so it looks like that the majority of you said none of the above. So I'm not sure what I missed, so maybe you can type down in the chat room what I missed when I put this up here. But it looks like 64% of you said that it was you're none of the above. Okay. So next question. We can reset the poll. Simulation experience. Do you have it? Do you have any simulation experience? Okay. So it looks like 62% of you do not have any simulation experience. So good. We're going to go through and we'll talk a little bit about simulation and how we can apply it into our respiratory care education within the hospital environment. So I'm sure you've all seen this. Respiratory care. We are specialized in the promotion of optimum cardiopulmonary function and health. We apply those principles to prevent, identify, and treat those acute and chronic patients with problems with their cardiopulmonary function. But as a respiratory therapist, we need to be up to date and proficient in everything we do. And so we are faced with a lot of challenges and constraints. Today, the two main challenges that we really struggle with are the acceleration of education of healthcare professionals. And then the other thing is really trying to maintain patient safety and keeping respiratory therapists confident in the rapidly changing healthcare environment and the rapidly changing technology. In the past, once you graduated from RT school, education usually included in-service, which we still do today on new equipment and procedures and practice by the apprentice style. I remember doing my first arterial blood gas on a person in the intensive care unit. Luckily, he wasn't awake, but I remember how nervous I was of doing that on a real person. What if I hurt him? What if I missed? So the nice thing about today is you have the ability by using skill trainers in simulation to practice that procedure prior to doing it on a real patient. However, we have to be careful with this heightened awareness of patient safety. And, because it really does decrease some of our exposures to these technical skills in the world. I remember doing an APRV in-service to a group of respiratory therapists probably about 20 years ago. And I remember having the ventilator in front of me, and I remember it was hooked up to, you know, a lung simulator, but, you know, it really was not hands-on. So, you know, when we finished, the expectation is that they should know it, right? Well, today, you know, that really doesn't work. Most people, if you don't use it, you lose it. And so we have to really think about how are we going to design innovative methods to train our respiratory therapists in the future. So in the past, traditional education extended the training time of people that when they were going through orientation. Because I remember going through my orientation where I first started in respiratory care, I probably had a 16 to 20 week orientation. I will tell you today that the orientation here at the Children's Hospital of Philadelphia is probably down to 8 weeks. And so we are really trying to accelerate education here and learning of our respiratory therapists because we really need them to get out into the field and work. So this advancements in technology and patient safety awareness, time constraints, and also the lack of people to do this education really exposes, you know, therapists to vulnerabilities. And so we really need to think how to get around that. And, you know, and what we have found that simulation can help that. Simulation can change that curve. Simulation can help them accelerate up that curve faster because they're doing it in front of them and practicing it in front of them. They're making mistakes in a simulated case and not making those, and they see what happens with those mistakes, and they won't make those mistakes then when they go out into the clinical field. Sorry, I had to get a drink of water. So next question for you guys. Do you use simulation-based education in training your respiratory therapist? All right, we close the poll. And it looks like the majority of you do not. So I'm hoping by the end of this presentation that I can charge you up enough that you really will think about how can I use simulation education to educate our therapists. And I'm going to tell you, and you'll see as we walk through this presentation, you do not need to have high-tech simulators. You do not need to have that whole immersive environment. You really need to start from the crux of what are you trying to teach your learners, your respiratory therapists, and how can I do it to make it the best educational experience. So what is simulation? So let's go through this a little bit, because we really need to think about creating new cost-effective ways to produce some measurable competence in our performance. And we all need to do that under the umbrella of patient safety. Now when people think about simulation, they think, oh my goodness, it's very high, it's high cost, you know, we don't have the money to do that. But I'm going to tell you, I know many, many people that have used a stuffed animal as their patient in front of them to do specific tasks. And I'm going to say, we'll talk about nursing at the moment, doing blood pressures on the stuffed animal, doing, you know, temperatures on the stuffed animal. So there's a lot of different ways that you can get around this and make it work for you. Educators need to know that simulation, the beauty of simulation is it really, adult learners absorb the knowledge and are able to apply it in the next situation. So they get these new, what they call concrete experiences that they can move forward with. And that, putting them in that experiential environment and immerse them into this problem-based learning really does make a difference. So knowing that, how do you define simulation? So here are those cadre of simulation definitions that are out there that you can probably pull a million of them. There's some kind of difference that people have to say about simulation. But what I'm going to show you over the next few slides is that there is commonalities in these simulation definitions. So the first commonality is that they all talk about experience. They all talk about the experiential experience. And that is a commonality in simulation that we all do. It's hands-on. It's called active learning. So we really get immersed into what we're doing because we are going to carry this forward. But then the next piece of that is that it mimics and replicates, or it's an artificial representation of what the real life environment is. So the more real you make it to your learners, the more concrete of experience it will be for them. But you're going to learn that it's not necessarily about the high technology. It might be about the high fidelity in making it real, but it's not really about the high technology. The next commonality is it really is about a guided experience. We are really doing a sound educational product that is landed with clear, common objectives. You are meeting the needs of your targeted learners, in this case, respiratory therapists. So you really want to make sure you keep it that way so they will feel it's relevant to them. The next one is processes or conditions. So we're really doing real-world processes and conditions that we are being exposed to every day in our real clinical world. Maybe you want to practice those high-risk, low-volume events that you rarely see, right? So you'll see later on in this presentation, there's times here that we use inhaled isoflurane for the treatment of asthmatics or the treatment of kids with uncontrollable seizures. But we don't do that every day. So the question is when that does come around, what can I do to help that respiratory therapist in making sure they are competent in managing that patient on that particular therapy? So take all those words and put them together, and you have a very simple definition for simulation. It's a creative, guided experiences that mimic real-world processes or conditions to achieve educational goals. It's pretty simple once you break it down. So they all are common when you're looking at those definitions. So let's move forward. Next question. Why use simulation? What do you guys think? It's okay if you want to be the outcast and think it's fun. All right, let me close the poll. Okay. So new fad in education. Nobody, there's 67 people that did not answer. So, I mean, really it's the experiential learning. And I think most of you have gotten that and have answered it that way. It's all about the experiential process. I don't know about you, but if you think about all the years that you went through schooling, kids do phenomenally well in elementary school. What do they do in elementary school? It's experiential learning. And then we move kids into the higher grades and expect them to sit in a classroom for 45 minutes and pay attention. So we take away one of our learning styles or learning methods when we're moving into that higher education. And that's why, as adult learners, we prefer to do it in the hands-on way. At least they have shown healthcare professionals prefer doing it in the hands-on way. So why simulation? We're looking at systematic approaches. We're really trying to improve a learner's self-confidence and their ability to learn. We really, the patients have the right to receive the best care that can be reasonably provided to them. It's understood that, you know, healthcare professionals are in training and do treat patients. However, when you think of it from an ethical perspective, harm to patients as a byproduct of training or lack of experience is justified only after maximizing approach like simulation that do not put participants at risk. So we need to think about our patients in the end, right? Because we have to think of the end is in mind. Our patients are the ones that are going to suffer if we don't prepare ourselves on how to care for them. So we're trying to prevent that, and we prevent that by using, you know, minimizing risk for patients and harm, and, you know, really not allowing our trainees to have their first encounters with their real patients. So we use simulation as one methodology that we can use. It's not the only educational tool out there, but it is one that if it's used correctly, it can be very effective. But you have to remember that simulation is not something that you design on the fly. It's something that is a very structured exercise with targeted objectives and outcomes. So we really need to look at this, because I feel what I'm seeing as the evolution of simulation is moving forward. It's going to be something that's going to be utilized in competency and testing as we move forward in respiratory care, move forward in medical education. You know, we are already seeing those trends occurring. And I will tell you, when you look at competence and performance assessment, our professional development educator here at the Children's Hospital of Philadelphia actively uses simulation continuously in an orientation program, in a competency-based program, and people have to be checked off in the simulation environment in order to move forward. Now, that being said, simulation, saying, yes, I did it right in the simulation environment, doesn't necessarily mean that I'm going to do it right in the real environment. But it will heighten my awareness of what is harmful and what is not harmful. So when you think about simulation, it really is about, you know, we really don't want to allow novices to repeatedly make mistakes on the real person that's out there. You know, repetitive practice is what we say helps you remember and do it better the next time. And though, you know, as it says on the slide, Vince Lombardi says perfect practice makes perfect, what you really want is practice makes perfect permanent. So we want to make it part of our concrete know-how. We want to make sure that it's embedded into us. You know, and we're only going to be able to do that by doing repetitive practice over and over and over again. And that happens by putting people in these learning experiences so they can get that new experience. And the nice thing about experiential learning is you learn from each other. You don't necessarily have to know it all. And if you put a group of multidisciplinary learners within that room and say you were the respiratory therapist within that event, you have clinical know-how that you can share with the people that are in that event, and they have clinical know-how that they can share with you. So we all learn together. And so moving forward, one of the things that we have to do as respiratory therapists and as healthcare professionals is we all need to learn to play in the same sandbox. We all grew up in silos. I know I grew up in a silo as a respiratory therapist, and we all grew up in silos, but now we need to learn to train together to be that high reliable team. And that only comes from us practicing together. So when you think about simulation, again, you know, all these different reasons why, when you use simulation, you can front load the training, particularly for new staff or students, so you can guarantee certain competencies early in their career. You know, when you think of the number of attempts it takes to master a skill, no matter how complex it is, it may not change. But if you actually add simulation to that change and do these short, rapid fire, get people in there, get them to do that deliberative practice, you will see that it actually shortens your learning curve. They will actually climb faster to get up there because they're doing it. They're not listening to it. They're not watching it. They're doing it. So you get them out there and get them to practice, practice, practice. You know, so when I hear somebody say, oh, I've just practiced again, and then they practice it, oh, I forgot about that. And you realize that your practice really was important for them. So we need to get people to progress towards mastery learning so that they know that skill and don't have to think about it when they come upon it. But what makes simulation effective? So some of the things that are put out there by Barry Eisenberg and Bill McGahey, who are some of the big people out there in simulation who really advocate about this mastery learning, is that, you know, providing people feedback, giving people constructive feedback. And this isn't negative feedback, which is what a lot of people think. In the healthcare environment today, negative feedback does nothing. So what we really need to do is constructively speak to people. You know, help them self-critique themselves. And we knew that, we know that that works, because if you're looking at yourself and how I could improve as a practitioner, there's things that, you know, that's what makes it more effective. And, you know, the other things that make simulation effective is that we control the environment. You know, we do define the outcomes of what people are doing and the strategies for how they're doing it. And then there's that nice matching of curriculum integration. You know, if you think about when you go through school, I'm pretty sure we all know that the curriculum that we learn from early learning all the way through, say, high school, that's all a curriculum that's been designed. And that curriculum is meant to build on what you learned previously. So, you know, if you learn algebra, then the next time you learn geometry, then you use advanced algebra. And it all builds on all the same concepts, so that you don't have to take on more than you can handle at the level of training that you are at. So let's look at this as an education redesign. This is how we can get simulation into it. We need to look at this new educational vision. You know, it needs to be more holistic. You know, we need to look at where are those learning opportunities. How can we adapt to an individual's learning needs? You know, everybody has different learning styles. So some people learn by listening, some people learn by seeing, some people learn by doing. But how, as educators, can we make them all part of that educational process? Because, you know, when we do some of our multidisciplinary simulations here, which always includes the respiratory therapist, they come, they do it, we have a discussion afterwards, which is called a debriefing. And then after the debriefing, our key facilitator will actually send out a document of the key discussion points. Because maybe I missed a learner type during this simulation exercise. And some people like to have that document to look at. I'm one of those people that, you know, I go to learn something out of a textbook and I seem to write the same thing on a paper right next to me, even though it's right there in the textbook. But me writing it down helps me remember what I learned through that textbook. So as, you know, us being professional educators, we need to figure out what is that best learning methodology for our audience. So why do we have to change? Well, I think we've said this already exhaustively, but, you know, the advancement of medicine, evidence-based medicine is evolving every day. Things are changing every day. We really need to be, you know, we've been told from the Institute of Medicine that we need to work better as teams. And we struggle with that in healthcare because we are so heterogeneous, right? It's not the same team every time we come together. So what we need to learn is the principles behind that team so that when we come together, we're all doing the same principles. And when you look at what the ARC puts out, right, the competencies of 2015 and beyond, and I'm pretty sure all of you guys have seen these. When you look at these competencies, you know, we really need to be comfortable in all of these different competencies moving forward. What they say is a competent RT workforce in 2015 and beyond must focus on improving quality, reducing costs through utilization of evidence-based medicine protocols, and improving patient movement across the continuum of care. You know, you go in for appendicitis today, you're not in the hospital for a week, you're in the hospital for maybe a day or two. So how can we move these people across this continuum of care and still accomplish what we need to do and give them what they need to get. The other thing you need to do is they really narrow it down to these 4 key elements. They really are looking at patient assessment, psychomotor, your decision making, and how do we critically think. We need to, I have to tell you, we need to sometimes teach people how to do this. To some people, it's not easy for them to critically think through a process. So why not put them through a simulation? You can help walk them through that process. What are they looking for? What are they assessing for? Why do these 5 things fit together to make this puzzle, and these 5 things over here are missing a piece of the puzzle? So you need to really teach people how to, in medicine we call it pattern match. And how do we teach people to pattern match for one thing, for decision-making processes, but not make them be biased that they're going down one pathway? But also, how can we teach them how to critically think? When you look at the NBRC, they use this Miller's Pyramid that's been out there for a pretty long time, since I think the 60s is when it really came out. And so we all go and take those written exams, and that really is just testing our knowledge and maybe potentially our competence. But it's really what we need to be out there doing is that they need to show us and perform us on the different clinical skills or the different critical thinking skills that they're using in the real clinical environment. And then once it becomes part of their know-how, then they actually, probably will then become part of your educational chain. They might become part of being your training team, and they're the people that you really want to solicit help from. The best practice in simulation is really grounded by a plethora of learning theories that are out there. And there is no one learning theory that really fits best with simulation-based education. But I just wrote a few of them that are down here in case you were interested in looking at them, but because I really don't have the opportunity to go into all of these learning theories. But they're really nice to go and explore, and it's funny to see when you look at them how much they cross each other in simulation, for simulation education. So let's move forward and talk about curriculum development, because this is where you start. So, time for you guys to answer another question. What is meant by curriculum design? All right, let's bring up the poll. All right, so it's a set of learning experience that has outcomes, correct, for the people that answered it. But when you really think about it, curriculum is what your learners will learn, while instruction is what they do, how they learn it. And so when we look at this, one of the things we need to really think about is what is an assessment going to look like when we're teaching people what they're learning. So when you blend it all together, it really is the learners, what is the subject matter, how will people learn it, and what are the capabilities of the instructional strategies or medium that's out there so we can produce a quality sound product to help facilitate their learning. Since simulation is really considered an educational tool, you shouldn't start with building a simulation. And I say this because every day, even 10 years, 15 years into simulation, of me for 10 years and some of my colleagues for 15 years, people still knock on my door and say, I have a great idea for a simulation. You really should follow the curriculum design process. And that begins with doing the initial assessment. And that initial assessment really pulls apart what are the performance gaps or what are the performance needs. So what I did is simplify it down into a 5-step process. There are a million curriculum design and instructional design models out there, but they all pretty much say the same thing. So we're going to really take a look at some of the process of the curriculum design, but I'm not going to go over the whole process of the curriculum design. So the first thing that you need to do is a needs analysis. You know, and as educators, we need to learn how to close those gaps or those needs of our learners. But what is a need? If you look at the definition of what a need is, it is a gap or discrepancy between the present state of what you're doing now and what your desired state is what we should be doing. The need is neither the present nor the future, and the gap is what's between them. So as an educator or as a person that's working within the clinical field, you must differentiate on what actually really is a performance gap or what really actually is a motivational or resource problem. Or is there a gap because there's something that is impeding these RTs from doing their job? So you really, as you do these needs analysis and actually close the gap, what you're doing is evaluating all those different pieces. Is it motivation? Is there some barriers that they can't do it? Because it really doesn't help if you bring somebody to a simulation environment and they go through this whole simulation and they're like, great, this is wonderful, this is good, and then they don't go out and transfer their skills to the real environment. And then you find out when they come back and they do it again, they say, well, we really can't do it because of X, Y, and Z, because this is impeding me from doing that. So part of this analysis also says, what are those barriers? What prevents people from doing what they should be doing? So when you look at most needs assessments, they're targeted towards a specific audience. Now, for you, it could be just the respiratory therapist, or maybe you're part of this multidisciplinary group that's designing simulations for your team. But once you've identified your audience, you really need to look at their past experiences, their knowledge, their skills, how they perform, and how they learn. You also need to know a little bit about what are their work responsibilities. So now, if RTs are your targeted learners, and you are the educator or the staff person responsible for doing the education, you're going to know what their responsibilities are in their environment. But you need to understand them, and you need to make sure as you're designing this that it's a rich and meaningful learning experiences. All humans are wired to learn, but there is really not a time when we are not learning. And I'm pretty sure from today I'll probably learn something from you guys. Learning is what we do. We learn something every day, whether you think is very menial and doesn't really make any difference. I live with a family of men, and so I have all these little things they tell me every day, which really doesn't mean anything to me in my life, but to them it's a joy. So we really need to think about what are those things that we need to target for our learners. And once we've identified what we're targeting for our learners and really looking at that goal and learning objectives, we have to really decide what is the appropriate educational modality or strategy. Because we've identified these gaps, now we have to figure out how do we close them. Now when you look at, and I'm going to specifically focus on simulations since that is my world, are the objectives of higher level? Do we need to apply them? Do people need to do them? Can a simulator provide the necessary fidelity, or do we not need a simulator to provide that fidelity? Do the learners need to do a little bit of experimentation? I'm learning a new modality of, ventilator modality, and do I need to play with it and learn how to do the appropriate things for my patient? Do I need to talk about it? Do I need to experience? And we always say that the simulation exercise is the means to get to the debriefing, or the means to get to the discussion. And when we get to that discussion, that's where we really learn about why we do what we do. That's where we really get to explore people's minds to figure out why you did it one way and why this person did it another way. And what we find out is it's probably somewhere in between, or a cumulative effect of both of you together. So that takes a lot to do. And, starting tomorrow, I'm training 9 people how to be reflective debriefers and how to really, what we call, get into people's psyche to figure out why they do what they do. And so it takes a little bit of skill to do that, and we train people every day. But when you do that and think about that, and you think that it's a higher learning objective, what type of simulation modality could I use? Could I use a high technology mannequin like our SimBaby or SimMan, or a low technology mannequin, which is Megaco Kid, who doesn't do anything, but he is a body that's there, and he does have breath sounds, but his chest doesn't go up and down? Or does it really hone down to that people just need to do the task training? So you really have to think about how you're going to pull that together to make it a more meaningful experience. The other thing that it might be, too, is you need to do the skill training first because they don't have the technical thing for those skills, and then take those skills and put them in a real clinical simulated scenario. So it's all fine and dandy when we teach people how to put on restraints on people, but when you put them in the real world, putting people on restraints is a little bit more difficult because they're moving targets. So you really need to think about, what does that look like and how can I make it more relevant to my audience? So for people there's a few people out there that have used simulation. What type of simulation modalities have you used? If you want to answer your poll again. All right, we can close the polls because I want to move forward. And it looks like there's very little experience in using some of the modalities out there. So we'll go through them very quickly because I really would like to get to talking about the educator of the future. But these are some partial skill trainers. They allow learners to practice on one specific task. So maybe you need to practice, doing arterial blood gas, or maybe you need to practice if in your institution you are the intubation person. Maybe you need to practice that, because even with intubations, some of the published studies are out there say that you need to do X amount of intubations before actually people deem that you're competent or deem that you're a master at it. So we need to be able to give people that opportunity. But as I said before, some things you might not really use low fidelity BLS mannequins. So this is that Annie, are you okay? I don't know, are people, depends on your age out there whether you remember Annie. We know that she's always dead. But what does you could use it, what does a dead patient look like? What are you looking for? You walk in a room, the patient's not responsive to you. Just even practicing those beginning recognition skills of basic life support are important, right? Because what happens most of the time is people go in and they do not recognize it. And so there's a delay of a patient getting CPR. So that's just as important for a respiratory therapist as it is for a nurse, as it is for a physician. Sometimes you can use these medium fidelity guys that are out there, and they have some realistic features on them. They still lack some things, but some have breath sounds. Most of them don't have chest wall movement. Most of them might be able to feel a pulse, but it's a manual pulse that you're the person that's spontaneously doing it. Or maybe it's just, as you see the little trach baby there, maybe it's just, what are the things that we need to do? That trach baby actually is a doll that we put a hole in the neck so that we could practice trach procedures with our staff, and then we kind of, changed up the environment a little and made them have trach emergencies. But it really didn't take much to do it. So you can really think out of the box on how I can do these simulation exercises. Now, if you step it up a little bit, and this is our inhaled anesthetic simulation, so when you look at it, you see the Draeger Apollo machine, which is what we use here. The mannequin that it's attached to is really a low-tech simulator. You intubate her, her chest goes up and down. She really doesn't have any pulses. But if you can see behind the scene, there's a monitor behind her, and what we have done is interface the computers up there with the simulated vital signs. Tell you what, there's a lot of apps out there today that you can bring across an iPad and simulate those vital signs. You don't need to go out and buy this stuff that's being made by these simulation companies. You can buy that little app and put it up with a little iPad or one of those devices, and voila, you have it actually good to go. But there are some simulations that, really when you look at integrated clinical simulations or immersive simulations that really sometimes really do need those high technologies. And you really need that technology to do what you want it to do. So we really always use, in our institution, we use high technology for a lot of our interdisciplinary training so that people can get the full experience of the mannequin giving them feedback along with them being in that simulated environment. Now, though you guys might not know this, at the Children's Hospital of Philadelphia, all of our simulations are done in situ. And in situ means that we go to the clinical arena, they don't come to us. So when I'm doing simulations, I'm doing it in their real world. And so they get to use their real stuff. And so it really does help them engage more into the simulation. Now, I know that some of my simulation colleagues who have simulation centers would argue with me that, you can have that happen also in a simulation center, and I agree. Because I'm going to tell you, last winter, I ran a simulation course for anesthesiologists in conference rooms, and they had no idea they were engaged into the simulated environment that they were in a conference room. So we brought all the props and the machines that really made it seem like they were in the real world. One of the common simulations that we run here every year, especially in pediatrics, is asthma. And one of the things, our identified need here when you talk about asthma simulation is that we run magnesium sulfate infusions on our regular inpatient ward. The problem is that the education modality that went out to teach the nurses and respiratory therapists about the administration of sulfate and looking for these side effects and, who needs to be there and the treatment of it was done by a PowerPoint. Well, that didn't work. So we designed a simulation with the same principles from the educational objectives that they designed for the PowerPoint, but made it active. So remember, when you're designing a simulation, it has to be active, not passive, because you're not going to get anything out of it if everybody's standing around looking at each other. One of the newer simulations that we're now doing in the past year is really jet ventilation simulations. The problem is, though, it's very difficult to jet ventilate these mannequins. So we had to do some jet adaptation, and these are a couple pictures of how we did it. We actually had to, because these mannequins, their lungs are open. They're not really closed. They're not closed systems. So you have to compensate for that so you can actually get the feedback onto the jet ventilator. So we actually had to get a regular lung simulator and key it into the jet ventilator in order for us to be able to simulate the training for jet ventilation simulation. So they run through a series of different scenarios of things that could happen within the clinical environment and alarms and how to troubleshoot things or how to manipulate the patient if their CO2 is too high or if their oxygen is too low, and what do they need to do and what are the changes they need to make. And so they spent an hour in this room going through all these different scenarios on how they would care for that patient. I'm not going to spend a lot on computer-assisted simulations, but they are out there. The NVRC has the clinical simulations, and so they are out there and they are a good modality, but they're like, I would call them a first-line modality before you move forward into really immersing people into simulation. And then there's these virtual reality simulators, and the bronchoscopy one we use quite religiously here to train our pulmonary physicians. And our respiratory therapists here are the assistants for bronchoscopy, so they also assist them when they're doing their virtual reality simulation. And though I won't cover standardized patients and confederates, one of the things that really, when you think about simulations, the things that we like to use sometimes are these standardized patients to be the real patient, and I'll show you one in a little bit that Julianne does out of Johns Hopkins University, or using people to replicate different things. And then there's a hybrid simulation, and I'm going to really point out the one that's in the middle, which is the ABG wrist with a standardized patient. Julianne is sitting there, and she's a good friend of mine. She's also a respiratory therapist and a simulation educator at Johns Hopkins, and she actually is the patient who's getting an arterial blood gas drawn. But what's sitting on top of her arm that she's actually holding is a partial pass trainer. And so here comes the place where you need to learn how to communicate. You need to do a blood gas on this patient for a specific reason, and you need to talk to them and tell them what you're doing and the procedure you're doing and why you're doing it. So what better place to practice this on how to do it and how to communicate than in a simulated environment? This doesn't take much to do. I mean, you can just design a little block that looks like, a wrist. We've designed them with little molds and jellos and put them on top of the wrist for people to stick in to learn how to do that communication piece. So in the last, I'm going to try to speed this up in the last so we can get to questions. 5 minutes, I really want to talk about the role of the hospital-based educator in the future. What do we need to overcome? Well, one of the things that we really need to overcome is, time. Time is a factor for us. We need a lot of time in order to train people in what they need to do. But there really is a gap for that between, what we need to do and the time that we're given. And so for that reason, when we get people into these simulation environments, we really need to engage them in purposeful, meaningful events. It really needs to be targeted around what they need because of this limited time. So whether you bring them there for a short stint of 30 minutes or bring them there for a long, event of 4 hours or 2 hours or 8 hours, we really need to make it meaningful and relevant. The other thing is too often we develop, different learning events that really de-emphasize the right process. So when they're looking to design something, whether having people follow a protocol or the protocol has been modified and changed, so now you want them to be in the simulated event of the new process or the new protocol, we really need to make sure that people really follow that process and follow that protocol. The other piece about process is we really need to focus on the curriculum process. We need to develop robust educational products that are really around an identified need or gap or discrepancy. Tradition is always a barrier. It really is where we've come from. I've come from, I grew up in my discipline as a respiratory therapist. I trained as a respiratory therapist with respiratory therapists, and now you want me to work with who? We really need to get people to get over that. We really need to get people to play in the sandbox and talk to each other. We also need to get our educators up to speed. They need to learn how to use a curriculum process and make focused learning. We really cannot fall back on that traditional educational method. Though I'm doing a lecture to you guys right now, I'm hoping I'm making it interesting enough that you're going to take something out of it. But I know that we are now 50 minutes into the lecture, and I could have lost half of you at the 20-minute mark, because in lectures, a lot of times you lose people at the 20-minute mark. And you really need to know, when you develop an educational activity with a group, you will find that some people are competitive. Each person has their own ideas of what those end products should look like for that educational mission. So we need to make sure we set up the standards, the norms, the procedures to help them break down barriers as you bring people together to design an educational product. It really becomes sticky if you don't have them in place. And then they will actually conflict. But I'm going to tell you that conflicts isn't always bad, because what happens, they have to actually think out of the box when they're conflicting, and they have to create a higher level of thinking and maybe a better curriculum and a better simulated event. But people that are educators need to also deal with the motivational factor. You know, high levels of motivation predict not only what one learns, but how one learns. So understanding and intervening effectively in the real motivation are very important. You know, motivation is a function of the drive to satisfy an individual or group's need. And if the instructor negates the relevance or doesn't reflect on the learner's understanding or misunderstands, the motivation of the learner is going to be difficult to deal with. And so we don't want to have happen that we have people start having disruptive behaviors within your simulation educational forum, because they're even more difficult to deal with. So when you think about it, our ultimate goal as educators is to create learning experiences that result in crossing the finish line with transferable skills. 21st century education is hard. The pace of education is different. And as it unfolds, it's really going to be extensive, comprehensive experiences that we have to do to cope with the challenges of the environment we live in today. Healthcare systems worldwide are under pressures, and together they result in less than optimal educational experiences for our learners. So we really need to, come to grips with this ongoing and challenging changes and make it better education for our learners. One size does not fit all. We need to adapt to make people learn. And I'm done. Any questions?
Robbie, that was wonderful. I've been taking notes over here, and as you and I talked before the session, I had the pleasure of hanging out with you and Julianne at the Summer Forum in 2012 when we had a whole pre-course dedicated to simulation. So one of the questions I had for Robbie at that point, and kind of an ongoing thing, you talked about a difference between using a high-fidelity mannequin versus a low-fidelity mannequin, and the cost difference in that can be significant, especially if we're looking at our educational programs who are a little on the strapped for cash side. So how do you decide if high fidelity is the only way to go for a certain task, or whether you can utilize low fidelity?
So that goes back to matching those objectives that you have with the educational strategy. And I'm not sure if I can convey exactly what I want to say, but does it require the respiratory therapist to be able to see that the mannequin's eyes are blinking? Does it require, if you look at the different things that high technology brings as compared to low technology or medium technology, does it require their chest to go up and down? If we're, spontaneously. If we're part of the learning objectives is to recognize, identify apnea. And I'm just picking something very simple. You don't need that high technology mannequin to recognize apnea. You just put a low technology mannequin there that you can actually do bag valve mask or bag mask ventilation on them. So you don't need all those bells and whistles. So it really comes down to evaluating on whether I need those bells and whistles or not. Do I really need, if I'm doing a straight respiratory distress scenario, does it matter to me at that point, depending on the level of my learners, that I need to worry about the mannequin having pulses? So It's a matter of matching what you're doing with the technology that's out there. And I have run many, many simulations, and I will tell you a friend of mine, Lou Hamelick, out of the Center for Pediatric Advanced Education out in Stanford, rarely uses high technology. What he does use, though, even though he uses a static mannequin, is he does use those vital sign apps to give people that, you know, the sound of that pulse oximeter. To me, the sound of a pulse oximeter as a respiratory therapist is more important to me than me being able to palpate a pulse if that's not part of my learning objectives. So you really need to evaluate what that is. And I'm going to tell you, with a medium fidelity mannequin that you can bag mask ventilate, or you can do manual pulses, you can insert endotracheal tubes, you can put in nasal airways, you can put oral airways in. You can do quite a bit with that mannequin. And I'm going to tell you, in our beginning years here, that's all I used. And our respiratory therapist, our professional developed person, that's all she used. And today, most of the times, as her respiratory simulations, the mannequin that she has is there is really just a prop for her to use. You know, they're doing all the changes that they're learning, the jet ventilation, that we're looking possibly at the vital signs that change according to the changes that the therapists have made. You know, I could project that up there with an iPad with vital signs. So, which really does, that app doesn't really cost much, or it doesn't cost anything at all. So there's lots of ways to do it. You just have to see what works best for you. I don't advocate for people that are starting out to go out and buy a high technology mannequin. I'm not sure I would buy the lowest technology now, but I probably would buy something in the medium level. And there's ones that are out there that are medium level that do quite a bit that don't cost that much money.
Thank you very much, Robbie. Unfortunately, we are out of time. However, what I would love to be able to do is take the questions that we received in the chat room here and put them over in our simulation roundtable on AARC Connect.
Okay.
And that way you could respond to some questions, and maybe we could even get some dialogue going over in AARC Connect. Is that okay?
Yeah, that's absolutely fine.
Great, great. Well, Robbie, thank you again for joining us today.
Okay, thank you very much for having me.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.